Oh, there it
Yes.
goes.
A
Great.
little slow this morning. Yes.
All right, thank you. So our first order of business is to do the approval of the minutes. So I'm going to do a roll call first to see who all is here. And I'm going to start with Dawn Martner, our vice chair.
Present. Good morning.
Good morning. And Greg Clauser.
I am here.
Great. Chicky Flowers, are you here?
Good morning. Good morning.
Good
I am here.
morning. Thank you. Andy Fultz. There you are. Thank you for the thumbs up. And Kimberly Hendricks on phone today.
Here.
Thank you, Kimberly. Sean Parkman.
Here.
All right, Sean. And then Representative Nose.
Here.
This is great. We are all here today. Welcome, everyone. Thank you for being here and making time. We have, as we noted earlier, two folks who are taking time off from work and showing their dedication to the PEB board and are here. And the first order of business is to approve minutes from our June meeting. Do I have a motion?
I can motion to approve those as written.
All right, thanks, Greg. And do I have a second?
Second.
Thanks, Sean. All right, Dawn, how do you vote?
Approve.
Thank you. Greg is our first. Chicky, how do you vote?
I vote to approve, please.
Thank you. Andy, how do you vote? Okay, I see a thumbs up for an approval. Thank you. Kimberly, how do you vote?
Approve.
Thank you, Sean. And you are our second, so minutes are passed. All right, so I'm going to hand it over to Emery Chen. He is going to be discussing utilization. Emery, are you here? Oh, I see you on screen. Yes, you're here. I'm going to go on mute and give it to you.
Thank you. Can you hear me?
Yes, I can
Okay,
hear
good.
you.
Good. Okay, I just want to make sure I wasn't accidentally muted on the headphones here. But thank you, board chair. Today, this first presentation is going to be talking about the utilization. So this is taking a look at the claims over the last essentially 2-3 years and some of the trends that we can see. Later today, we're going to be presenting the RBC presentation, which kind of looks forward and looks at essentially the funding of the PEB plans. But this is kind of like a more historical look in this case. For the agenda, what we have today is shown here on this page. So we'll go over some of the typical utilization review with the aggregate cost, the trend components. We'll talk a little bit about the risk and efficiency, including some switching at the beginning of the year. So basically, you know, in terms of looking at plans and whether members moved in or out that were higher or lower risk, as well as the risk of those who left PEB completely. One new section in this presentation, taking a look at Z codes, essentially codes that help are diagnoses of social determinants of health. So these are part of the ICD-10 codes. We're taking a look at it, and the members who actually are flagged with the Z codes end up actually having different health conditions and different costs compared. And so we took a look at that as well as what some of the things, the plans, some of the things they do to help manage those members. And then we'll have some of the other typical looking at the clinical conditions, utilization trends, as well as different categories of services, and just kind of hopefully summarizing it up. We do have an hour and a half. I know these tend to run a little bit long, but please feel free to interrupt, ask questions as you go through, and we'll try to make it fit in the time allotted. But moving on to the next section, data and assumptions. So we'll go through this real quick. Just to note, we are looking at incurred claims, and we are looking over the last 3 years in the time period ending December 22. For the incurred claims time period, we do look for additional runout, so that's why it's a little bit delayed. You know, we are in July, but you know, we do want to have a little bit more information, so we're more sure about the claims that are coming in. And so we do have the self-insured plans there, statewide, choice and MOTA, and the two fully insured plans, which are Kaiser HMO and Kaiser Deductible. We do include some Kaiser reporting for integrated care fees. These do not come through in the claims, so we add them in when we take a look at some of the overall cost comparisons. And for the self-insured plans, we do remove rebates in certain reports for medical and pharmacy. Moving on to the next section, aggregate costs. So this is taking a look at the claims on over the 12-month time periods. We have 2 year prior on the left, 1 year prior, and then moving to the right, you have the current time period. This first slide does show the self-insured. One thing to note, this is based from the claims system. The financial systems might have slightly different amounts or timing on reporting, so they may not tie exactly, but it's usually pretty closely in line between those two. And over at the top, you can see the aggregate cost for the self-insured plan. So overall, you're at just over, on the far hand right column, in the current, you have just over $700 million in annual costs. And that doesn't include admin, but does include offsets for rebates. And that's about a 2.7% change from the prior year. If you take a look a couple columns over on the percentage change for the 1 year prior versus 2 year prior, you see a pretty big increase of 16.5%. But that's really due to return to services from COVID. So that change is really 21 versus 20. 20 had a depressed utilization. So, I guess we're getting to that new normal. And so the 22 versus 21 is probably closer to what we would now expect as typical trend. It is a little bit lower than the 3.4% limitation, which is good. And based on the renewal results, we were just under the 3.4. But on the per employee per year basis, ended up being about 2.1%. The number of employees is growing a little bit, but the number of members is actually decreasing a little bit. So you might be losing some, like few more dependents, the overall cost, but not too big of a change in the annual membership in this case. Next slide, please. Thank you. Fully insured. So these are the Kaiser costs. You can see that the overall increase on an aggregate basis there on the top right-hand corner is about 2.5%. That's about $171 million for the current time period versus about $167 million for the prior time period. The employees per year, on a per employee per year basis, that's about a 1.5% increase for the current time period. The prior time period was about 12.8% increase with return to services. Similar story with the membership in terms of number of employees. It is growing for Kaiser, but the number of members is decreasing a little bit in this case. So overall, the costs are increasing here below the 3.4% when you're looking at it on a per employee or per member basis.
And
Okay.
Emery, I just have a question on this slide, and I know we're going to go more in the weeds in your presentation, but the numbers on Kaiser are much lower than the increase that we are going to be seeing our rates increase for 2024, correct? I mean, I just want to make sure that we're clear that our utilization did not back up the increase that we saw from Kaiser. Is that right?
Yes, this is, like I mentioned earlier, this is from the claim system, the financials, and based on the claim system, yes, the increase you can see here is a bit smaller than the overall increase for Kaiser. When you take a look at on the financial system, the timing's a little bit different, the dollars are a little bit different, and the costs on a percentage basis do increase a little bit more, increase more than what you're seeing here. So those align a little bit more closely with the overall rate increase. But both of them are below the rate increases that were approved by the board.
Okay, thank you. And Dawn, did you come off mute? No? Yes?
I did.
Go ahead.
I'd like to mark that question as one that I'd like to understand better by the end of the day. I'll defer any questions for now. If I understand it correctly, what you said is that these numbers do not include administrative costs.
No.
And those numbers do, right?
They do, yes. the systems, it's really more of a systems issue. Financial reporting systems are different from the claims reporting systems for most plans. And what we get for this database is different. So the timing of when a claim's reported versus, the amounts are, essentially the timing of when those claims are reported gets different. So when we're taking a look at discrete time periods, there might be a little bit of a difference, which can impact it in case of, lag or other types of timings in that case. So there is a kind of a technical aspect to that. Unfortunately, it exists, but it is something that, I guess in this case, does plays a little bit of a role in why these numbers are a bit lower in this case. So
Thanks, Emery.
Yeah. Moving on to the next slide. Total PEBB cost, so combined self-insured and fully insured. So I guess, based on the prior two slides, everything's increasing below that 3.4% limitation. And in this case, it is, including the per employee amounts for medical and prescription drugs after rebates. So, it's relatively good news, at least when we're taking a look at the 21 versus 22 cost increases. But as we move on to the next section here, there might be a little bit, areas where we want to watch. So moving on to the trend components. So this trend component, the green is the prior year. So that big total annual increase at the top of 16.6% on a per member basis is really due to return of services. And you can see the utilization increase of 11.8% in green. In the blue, that's the current year increase. So the overall increase on a per member basis is 4.5%. This is a little bit higher than what's shown before because rebates are not included in this amount. Rebates have been increasing quite a bit and offsetting a lot of the pharmacy costs. So this does not include the rebate. Utilization actually has dropped when you take a look at prior year versus current year. That may sound a little odd, but really it's due to COVID because a lot of COVID services in terms of members going in, getting tests, vaccinations. And, vaccinations is a big one. Every time a member went in to get the vaccination or the booster, that counted as a utilization as a visit. And those costs were just for the administrative costs. The cost of drugs weren't included. And so that decrease in utilization did impact the unit cost that you see down below of 6.8%. So that 6.8% is really high, but a lot of it is due to basically the vaccinations going away, or at least members not getting nearly as many vaccinations as they did in 22 versus 21. There are also other cost increases that are impacting it, and we'll take a little bit more detail as outpatient costs do increase quite a bit, and that's, you can see in the note, outpatient surgery, mix of services, and the cost did increase, and usage of cancer drugs, especially pharmacy, did increase and impact that unit cost. And there's also some other unit cost increases. One area where we'll talk a little bit later and is, just noting maternity costs. I think with Senate Bill 1067, where there was that bump initially and then it came back down with the revision, the maternity costs look like they are kind of increasing a little bit in terms of percentages. So that's something we'll want to look at, and we're going to be doing some deeper dives into this sort of reporting for the IWG to take a closer look into like specific categories of service a little bit more. But maternity is one area where we'll want to make sure that the contracting isn't really increasing too much and impacting PEBB, considering how many births are happening for PEBB every year, which is over 2,000. The member risk is a slight increase. The prior year does include some of the utilization comeback. So that increase of risk wasn't really, it's just kind of like they were underreported in 2020 and then now they're kind of coming back. So the member risk isn't increasing that much for PEBB, which is good. So it's not a big impact on the overall cost. And then the cost share leveraging, this is how much the plan's picking up versus how much the member's picking up. So it's an impact of, I guess, trend on your plan designs. That does provide about 0.5% increase to the overall cost for PEBB. Any questions on this slide before we move on?
Emery, this is Representative Nose. Sorry, I'll figure out the raise hand function here. At the high level, the summary of this is people didn't use services during the pandemic. They came back and started using them. And now things have leveled off and we're not really seeing that dramatic an increase for this year, for this last year.
That is correct.
Okay.
Yeah.
Just making sure I'm
22.
tracking.
And since I think we've talked in prior renewals during the, I don't know if you listened in on the board meetings on some of the recordings, Representative, but we did increase the trend.
Sure did not.
On the projected. Okay. So we did increase the trend a bit. We've been hearing, with inflation and the issues with healthcare, that the costs are increasing. The providers, are having issues and the contracting is getting more difficult. So we did increase the trend, and you'll see that. I think we might mention it in the RBC presentation in the next one. So that's one thing that we just want to be aware of. While 22 isn't too bad, we just want to not be too overly, I guess, aggressive or be too confident on costs quite yet until we see what's happening for 23 and 24. Okay, thanks. Moving on to the next slide, we have the breakouts by the service categories here. And so as you can see, the different categories from left to right, you have inpatient to the left, outpatient in the middle. And you can see that the unit cost increase is quite a bit bigger in this case. I mentioned earlier the outpatient surgeries as well as the specialty drugs have played a role. Some of the COVID vaccinations also played a role in there. So that unit cost is quite a bit inflated in this case, decrease in utilization, as you can see, partially because of the COVID, lower COVID vaccinations, other COVID services. So there's kind of like an offsetting role in this case. For physician, very similar kind of impact. The physician utilization did go down a little bit, mainly due to COVID, and the unit cost did increase by 3.3%. But overall, physician costs kind of increasing where PEB in total has been, well, actually 0.7%. So it's a little bit lower than where PEB has been. And then on the pharmacy, you can see there on the increase is about 10.8% on a PM basis, and basically all of it due to unit cost. That is cost of drugs going up, especially some of the pharmacy, especially pharmacy in terms of the rheumatoid arthritis drugs. A lot of it is being offset by increased rebates. So there's kind of this rebates aren't being shown in here. So if we did take a look at RX, that 10.8% increase would be much lower. It could be closer to 4 to 5%. So you can see the impact of, the drug manufacturers increasing the rates, but essentially getting it back in the rebates in this case. And then all other there is on the right, which is increasing at 2.2%. So the two areas obviously of concern, outpatient services, and some of that's mixed, and then the pharmacy, which continues to have the higher drug costs in this case. Next slide, please. So taking a look by plan, some of the bigger areas of increases. So going from top to bottom, you have Providence at the top, largest increase in specialty drugs. And that is, again, the rheumatoid arthritis drugs. And you can see a pretty big increase in those costs. The outpatient surgery also had some big increases. There might be some returning of services. There's a mix of services where the outpatient surgery is a little bit higher. And there may be some shifting from inpatient services in some cases to outpatient, but not necessarily for Providence choice. As we take a look at statewide, inpatient surgical costs were increasing. But if you take a look over there on the right-hand side, the inpatient medical is kind of like classification differences. That decreased by almost the same amount. So overall for inpatient, it was kind of pretty flat. But specialty drugs, prescription specialty drugs, they increased quite a bit there. For MODA, again, the facility outpatient surgery, you can see the big increases. And again, a similar story on the inpatient medical, just a decrease out. It's just kind of an odd mixed difference there. And then specialty drugs also was another increase for MODA. And then Kaiser down below, maternity actually dropped for Kaiser deductible in terms of number. Kaiser HMO, the specialty drug costs are increasing and the maternity is increasing there. So this is just, well, I guess, maybe just randomness through the year where the deductible maternity is going down and Kaiser HMO is going up, but specialty drug costs are increasing, at least for the Kaiser HMO in this case. And as noted down below, there's some of it due to cancer treatments, which would increase the cost per service. Next slide, please. Taking a little bit closer look at the pharmacy trend, and this again is does not include rebates, so the trend here is a little bit higher. And this includes both PBM as well as specialty, professional, and outpatient. The drug costs increasing, at least for the PBM, about 6%. Most of it not for non-specialty. The specialty drug costs are increasing a bit more, which makes the overall drug cost increase quite a bit higher. Professional drugs, specialty drugs isn't increasing, a small drop, but the outpatient facility, I think, based on some of the information from the prior slide, you can see there is a bigger increase in that case. Taking a look on the next slide, we won't go into too much detail. I think a lot of this stuff we had talked about before, but if you take a look at the top, at least the 4 of the top 5 drugs, those are the rheumatoid arthritis drugs, and those have the biggest cost. You can, over on the right, there's the trend. So you have the scripts per patient. So the number of scripts per patient and the number of patients is increasing, but the total cost is increasing a bit more than the scripts per patient and patient. So that means the unit cost is increasing quite a bit, as well as the number of patients. Ozempic, which I know we've talked about and we're going to review, is the number 3 drug now. The costs are increasing in terms of the number of patients, and the cost per script increasing a little bit, but the number of patients basically doubled between 21 and 22. And so that basically made the cost go up from about 3 million to 5.3 million in this case.
Hey,
yes.
I just want to make sure that I'm paying attention on the Ozempic. That's one of those weight loss drugs, but currently people aren't being prescribed the drug for weight loss. It's only for diabetes for our folks, right? Yeah. Although we're seeing utilization increase.
Yes. Yeah, okay. It's a diabetic drug. It's a diabetic drug as listed there in the therapeutic class. I think a lot of people have been using it for weight loss. And I think one of the next slides talks about obesity, and the prevalence has increased over the most recent year. But yeah, it can be used Ozempic can be used essentially off-label, even though it's the same for weight loss in this case. So there's a couple of the red decreases. I think number 11 and number 19. So you can see the impact of the vaccines, where the cost and number of people using the vaccines has gone down. So that is a lower cost. It's just the administrative cost. The vaccine cost, ingredient cost, was being picked up by the government, but the number of drugs, number of vaccinations has gone down at the current time period. Next slide, please. This is just the medical pharmacy. There's a lot of changes across the top where it's just different drugs are being used, different cancer drugs or different other types of drugs. So overall, there's some big changes, but depending on the types of service, there has been a bit of an increase overall, as shown on the other slides, but won't go through nothing in detail. Next slide, please. So this next section talks about the risk and efficiency of plans. So this first slide shows the risk score for PEBB over the last couple of years. We do normalize to the 2021 time period, so you can say a 1.0 is an average PEBB member. So the risk score is essentially taking the claims of the member as well as the demographics and gender, age and gender, to kind of essentially come up with an expected cost for those members. 1.0 is in terms of average, we normalize it to a 1.0 for PEBB. So you can see where some plans have essentially a lower, risk mix and those who have a higher risk mix than PEB in total, as well as the change from prior year to the current year. So overall, you can see the biggest risk, highest risk is in the statewide plan. It did increase from 1.07 or 7% more costly to 8% more costly, at least in the current time period. The second highest is the MODA plan, which has one just above the PEB average in total. So, and that did increase by 1 point. For Providence in Kaiser plans, those are below. You can see Providence and Kaiser HMO are a bit, a couple points below. The Kaiser HMO risk did decrease a little bit. Kaiser deductible, it has tended always to have lower risk members. And so you can see that their risk is about almost 30% below PEB average in total. So this is the change between 21 and 22. Moving on to the next slide. We took a look at the open enrollment in terms of December 22 versus January 23 to see if there were like big changes in membership or big changes in risk that might impact the rates of the plans, or where the plan might end up for the next following year. And to make a long story short, no, there's not too much of a change. There was some switching. MODA has been increasing enrollment a little bit. A few people have been moving out statewide, but we're only talking a few hundred or 1,000. So it's not a huge change in terms of switching between the plans. And when we look at the risk score down at the bottom, the risk really isn't changing much at all as well. Those who do switch plans, which are cut in the middle, switch into and switched out of the plan, they are lower cost members who switch. But generally, it was pretty much a relatively even mix, I guess, when you're switching in and switching out. Those who left PEB, those generally are those who retire, although some people do leave PEB and leave their jobs. Those are a little bit more costly. So as the people leave PEB, those are a little bit more costly. You get some new members who come in who are usually a little bit more cheaper. We might see that PEB in total risk might not change, or might actually go down, or overall might be relatively stable coming in next year. So we're not anticipating that risk is going to play a big role in the cost of the plans moving forward. It's more likely going to be management of the plans and contracting, at least for the 23 time period. Next slide, please. This slide we show during every utilization report. So it's taking a look at the normalized cost by plan. So what we do is we take their claims based on the utilization report, add in admin and other fees or rebates. So in this case, the admin and rebates are in purple, and you can see for Providence and statewide, they're actually down below because the rebates offset the admin fees in this case. MODA, the rebates mostly offset admin fees, and then the Kaiser, you have your admin, they actually don't provide rebates as an offset, explicit offset to the cost. The other fees for Kaiser are some of the integrated care fees. They are included in the renewal rates, but they're not considered claims, so we added them in. And so what you can take a look at is for the bars, those are the costs based on the per member cost and claims in the blue, and then with the admin and other fees. And then what we do is we take a look at the risk. So, if you have a higher risk plan, you're like the statewide there on the right, your cost may be higher, at least on the absolute basis, but when you normalize it for your risk membership, the costs actually end up being, you have a more risky membership. And so your true cost of managing that member is a little bit lower. In this case, it's $545. This is based on the plan design. So, statewide does have a leaner plan design. So some of that's offsetting some of the costs. But the costs are, in this case, lower than Providence Choice. Providence Choice does have have a higher, richer plan design. So that $6 difference is really more plan design. But, overall, MODA has the lowest efficiency, lowest normalized cost at $508. And then there on the left, you can see the Kaiser HMO and Kaiser deductible normalized costs, which are higher than the other three plans. Any questions before we move on? Good. Next slide. So this next section, we're taking a look at the Z codes or the social determinant health codes. As you can see there on the left, the Z codes in terms of groupings, and there's more of them in each of those groupings, but you can see the various types of social determinants that you can, if the doctors can code for, based on what's presented during their exams or other medical events. So you can see for Z55 at the top, problems related to education and literacy, and then low educational and literacy issues. Employment and underemployment is listed as the second one, Z56, and you can see there on the right the number of members in PEBB that had those codes. And so for education literacy, there's about 319, and then 166 for those with employment and unemployment issues. There was one with occupational exposure to risk factors, none tied to physical environment. But then you start getting to some of those social determinants that I think we talk a lot about: housing, economic circumstances. There's about 54, social environment, 154, upbringing. You start getting into the more members here, about almost 650, and then for family circumstances, support group. So this is where the bulk of your members potentially have at least this social determinants coding. This is just those that are coded in this case. So those who have support group and family circumstances issues, about almost 3,000 of them. And then you have the psychological circumstances, including crime and other instances there, which is a little bit smaller in this case. So overall, about 2.7% of PEBB members, or about 3,600, do have a social determinant code. And you can see the coding by the different plans and the percentages by the plan. And Moda, province, choice, and statewide are both all below at PEBB average. Based on some studies, you might see about 2% of members being coded, at least on average. So, PEBB coding is pretty in line, but you can note that Kaiser Deductible, Kaiser HMO do have a lot more people who have been flagged as having the social determinants. And we talked, Mercer asked the plans about this social determinants coding and whether they made efforts to identify and code them. And Kaiser did note that since 2020, they've made a concerted effort. They've talked to providers and made a concerted effort to identify those social determinants and to code them. And so that may be part of the role and why you see that Kaiser's essentially above 5% of members that have those flags for social determinants in this case. There are other things that are going on that the plans are doing to help impact these members. We'll talk a little bit about it when we talk about their claims, but Kaiser at least is flagging this. And you can see there on the top, there are cost impacts due to this. Social determinants can impact about 10 to 15% of a member's risk score. So it's going to be pretty darn impactful on the risk of a member. And that social economic factors contribute to almost 50% of the health outcome score for a member. So it's really impactful in this case. And their costs definitely are higher, as we'll see on the next slide. But before we move on, I wanted to just kind of open up and see if there are any questions or comments about this slide in particular.
Just so that I'm understanding, Emery, I mean, we just saw risk scores for Kaiser Deductible being much lower than other plans. Mm-hmm. However, the numbers that are getting coded with these social determinants of health factors, you're saying the average in the book of business is around 2% get coded, and that Kaiser seems to be making more of an effort to follow up and do the coding with their folks. Yeah. Okay. Mm-hmm.
Yeah. Okay. Next slide. So what are the impacts on the health of the member as well as the cost? So we show a couple different looks at this. The ones on the left, you can see the members with the Z codes in the chart, where you can see the various breakouts in terms of types of services and their costs for those on a per member basis. And then on the right, those are the members who do not have the Z code. So the difference is about 60% higher cost for those with members with Z codes. Physician services are quite a bit higher. Prescription drugs is not quite as high, but there's a lot more, there's more inpatient services, and a lot of that is actually mental health and substance abuse inpatient services, as we'll see in the next slide. But overall, these members are more costly. So identifying and trying to treat those members, Kaiser identifying these members at least a little bit more, and will have the ability to impact their health quite a bit because, and help PEBB quite a bit, these members in PEBB quite a bit, because these members do have pretty costly health conditions. And you can see based on the types of Z codes there on the right, where the biggest impact, or the ones with the Z codes in terms of the biggest impact, the relative cost, housing and economic. So if you have housing insecurity, economic issues, your relative cost compared to a typical PEBB member is 3 times as high. So there's a lot of stressors and a lot of other things that may be impacting those members. So identifying those housing economic, trying to deal with those issues might be able to help manage those costs and to bring down the overall cost and just make your members' lives better in this case. Employment down below that is about 1.9, so that's very similar in terms of the housing economic, in terms of the monetary financial issues. So those are essentially the biggest impacts. The other impacts, about the 1.5, there's the psychosocial issues, but then the family support, which is the bulk upbringing, a lot of the mental health, just your family conditions, you're more costly by 50%, and you have those health conditions. There's lots of them. I think we've talked about integration of behavioral health and medical, and I think this is one area where we can maybe try to focus on in terms of identifying, making sure they're being identified, and that the care coordination between the mental and physical health is done once you identify who those members are in this case. Any questions, comments? Okay. Next slide. So in terms of the other impacts, cost impacts, this is where the more specific types of services, categories for these members with social determinants are more costly than a typical PEBB member. And you can see on the far hand left side, it's mental health and substance abuse. Their mental health, inpatient, substance abuse, inpatient. That's these are the members who are going and having those services. So it's that inpatient, that coordinated care, just trying to maybe work with them and maybe help the transition from leaving the mental health and substance abuse inpatient facilities and coordinating with RAP services in the community. Kaiser talked about some of their care coordinators and some of the programs that they have to help coordinate, to help direct these members potentially to services in your community, the RAP services to deal with the outpatient, to deal with the substance abuse and mental health services. MODA is implementing a program to help help coordinate, the behavioral health issues as well. So there are some things being done. Kaiser, I think, has been definitely a lot more proactive in terms of trying to manage these members, but this is where the impacts are happening. It's really with the mental health, inpatient, outpatient, and then you have some of the other specialty drugs, or the other services there, where it's like physician services are more costly, or more higher risk and more costly in this case. And they also do have more emergency room services. So that's, trying to maybe impact those who have manage the members, try not to have them going to especially emergency rooms as much as possible. Being on top of that care management might be able to really, well, help these members as well as bring down the cost in some cases. And was there a question?
It looks like Sean has a
Oh,
question. Go ahead, Sean.
yes.
Yeah, so I appreciate this discussion. Emery, do you have like an overall estimate? I mean, I see we're comparing costs between people with social determinants of health flags versus those that don't, and so on. But do you have a kind of a ballpark idea of the kind of, for lack of a better word, like additional spending we're doing based on these risk factors?
In terms of the absolute dollars?
Yeah.
Yeah, so if we go back one slide. So there on the left, these are the per member costs. So these members essentially are about $900 in terms of claims per member, which is compared to about $600. So we're talking about $300 per member per year. So about $3,600 per year. And we have 3,600 members who have been flagged. So I'm not going to do that math in my head, so I'm going to use my calculator. So we're talking about $13 million in additional costs compared to a typical PEBB member, which
All right.
It's about 1% of PEBB in total. But we are, I don't know, it's a lot of high cost behavioral health issues where it may not just necessarily impact that specific member. It also impacts your the families, the people surrounding them as well. When you have there's additional issues that may arise because of some of these social determinants rather than just that specific member. But overall, I guess to your question, it's about 13 million.
Okay.
And we're not tracking them all, right? I mean, like we have lots of people who have social determinants of health that are impacting health costs that aren't being tracked in these numbers, right?
That's very likely, yes.
Yeah.
I mean, the coding doesn't always get picked up. I mean, in terms of the types of things that people are being impacted. Yeah. I mean, they may not present them, they may not talk about them openly. I don't know if it's, if it's happening on, therapists, behavioral health outpatient visits. Those discussions may not be brought over into the coding for like the medical. And so there might be some ways to help integrate that and to identify people.
Yeah, I mean, I think your earlier point, Emery, I think is worth just kind of noting that I'm a little bit familiar with Kaiser's general effort to try to get these codes actually used, and it was quite an endeavor to get. It's a training thing for physicians, and as you can see, it sure enough did increase, and I think that's probably because they were using the code. They were training their physicians to use the code more often. So you can imagine without that kind of concerted, coordinated, centralized effort, that there would be a significant undercounting, in the other plans. So what I'm driving at here is, it's one thing to detect this stuff when you're talking about OHP, it's like we're an employer. So these are either our employees or their family members. And so I start to think, I mean, of course it's appropriate. Maybe it's the most appropriate thing for the plans to detect it and for the plans to coordinate a connection for these people to community-based organizations and whatever who can help address various other resources and so on. But if our employees are struggling with homelessness, houselessness, or mental illness or addiction service, struggling with that kind of dynamic, it seems to me that there's at least room for a conversation around some enterprise-wide investments in like some kind of deliberate supports, not necessarily in the workplace, but at least from the point of view of the employer. At the very least, there's the EAP. I mean, that's like level one, but it just get me thinking about a broader concept of worksite wellness, right? Or something like that, where there's kind of some ability to be able to connect to resources related to some social determinants of health for employees from an employer point of view. I don't think we really need to talk about that this very second, but I'm just putting that out there as kind of like a meta concept that maybe we want to talk about, because there's some additional responsibility in addition to the plans related to employees.
Ali?
Yeah, if I could just jump in really quick, Sean, that actually tees up one of the topics of our stabilization reserve discussion that we're going to have later in the agenda for specific investments around SDOH and some other areas. So we'll definitely talk about that in a little bit.
You and I did not plan that.
I know. That's perfect. That's perfect.
Yeah, thanks, Ali. I mean, that was my thought exactly. I mean, we had talked about, where can PEB make investments is, if there are surpluses, if there's money to help reduce overall trend or cost, health of the members. It's just like, it is one area for discussion for, maybe there's an explicit PEB board decision that can be made around, we want to fund these types of services for their members. So in terms of the, I think Dr. Bachman just put a note in the chat about, they do also believe that they are undercounting, even with the higher percentage, 5% of members identified. So that may still be a low number in this case. But yeah, definitely. Any other questions, comments?
Hi, Emery. Yeah, if I can just add on to what Dr. Bachman mentioned. I mean, what you are reporting here includes our community health navigators, which is where we provide the Z codes or load the Z codes into the system. And there's no claims attached to that, but there are other resources that we use. For one example is the Connections Call Center, and that's for low complexity individuals that we're not counting in the data here. And then the Resource Access Center, which supports members with medium complexity patients to help them, again, identify the resources that they need. So again, as Dr. Bachman mentioned, this definitely is an underrepresentation or undercount. And of course, Emery, I know that, this is from the claims data, which, we have the Z codes attached, but there are other services that we provide to connect people that's not included.
Thank you.
Thank you.
Thanks, Sapari.
Any other questions, comments? Okay, moving on. Thanks. So clinical conditions and utilization trends. So what we're taking a look here are essentially some of these chronic conditions conditions that are impacting the PEB members. We do highlight in red the most significant ones. So, taking a look there at the top, mental health, anxiety, and depression, they are essentially 2 of the 3 highest issues that we have identified. And the trend is, since COVID, since 2020, it has been increasing. For 21 versus 22 may just drop a little bit, but still significantly higher than where it was pre-COVID, essentially. Hypertension, about flat. Diabetes, their endocrine weight section, diabetes is about flat in terms of the prevalence, but you can see the obesity diagnosis has gone up, especially since COVID. I don't know how much of that's really necessarily tied to Ozempic, but the obesity, at least the coding for the prevalence, that's probably under compared to the overall level of prevalence of obesity in the population, but it has definitely increased by almost 30% in this case. And then lower back disorders, that's one of the areas where we're going to be looking into for the COE in the IWG in terms of spine, but lower back disorders also, it's increasing a little bit. Some of it may be tied to that, the obesity, impacts your weight, impacts your physical, the pain, and that's part of the issue. And so, and then taking a look at the information there on the bottom in terms of this overall spend by the different conditions, you can see that diabetes is the #1 rate cost over 21 and 22, and the spend has been increasing, going from 38 million to 43 million over time, and Ozempic is definitely playing a role in there. Osteoarthritis, the overall cost increase is smaller, but it's now #2 because the number of pregnancies went down a little bit. So while the pregnancies went down, the cost per pregnancy in some cases have gone up. I think some of the preemies have been lower cost in this case. And then depression is the #5 overall cost impact for PEBB. So that's taking a look at some of the clinical conditions. Moving on to the next slide. Preventive screening rates. This is one slide where we show the comparison of PEBB to Mercer book of business. While preventive screenings did improve from 20 to 21, they have gone down just a little bit between 21 and 22, and they also remain a little bit below the Mercer book of business in most cases. The two areas where they don't include breast cancer and colon cancer, but in terms of the number of preventive visits per member, those are well below the book of business. So that's one area where we may want to, where we've talked about, I think, over multiple times about trying to help impact the PEBB members and trying to get those, doing the outreach to get the members to have their preventive services in this space. Next slide. Moving on to the categories of service. So we take a look at these 5 categories there on the left: inpatient facility, outpatient office visits, and there's various areas there. The emergency room, lab, radiology, and prescription drugs. So for inpatient facility, utilization did decrease a little bit, but there's a little bit of a cost increase per admin. Outpatient office visits, mentioned earlier, the COVID vaccinations is kind of skewing the numbers a bit, but that's definitely playing a role there. Emergency room. The usage of emergency room went way down under COVID. Telemedicine went way up, but the emergency room usage has gone down or gone up quite a bit, and the telehealth has gone down a little bit. So emergency room, I know we PEBB made some changes for the Kaiser plans to kind of impact that, but the usage of emergency room continues to grow in this case. And then lab and radiology, small changes, but COVID tests are a big portion of it. And then prescription drugs, I think we've talked about quite a bit about that in the prior section. But moving on to each slide. Next slide, please. So again, inpatient facility, you can see there that the admits per 1,000 did decrease by 3%, but the allowed per admit did increase a little bit, kind of like almost a neutral offsetting of costs. Inpatient maternity cost per admit, as I mentioned earlier, is increasing. So some of those DRGs that we had looked at before, following the Senate Bill 1067 implementation, these areas are increasing by essentially double digits. So normal newborn cost per admin is increasing 20%. Deliveries, neonates, and C-sections are increasing about 10%. So this is one area where I think we'll want to just make sure, take a look at the utilization, the different facilities, different plans, and just making sure that there isn't too much of a growth in these costs, especially since they are below the 200% Medicare level, and there is unfortunately room where the plans, where the cost may end up being could grow significantly without violating that violating
So
the legislation.
I just wanted to check on that, Emery. Thanks for lifting this up. I thought we had addressed this and got some money back from the carriers. Am I remembering incorrectly?
Yeah, I'm not sure you necessarily got money back from carriers, but in terms of the clarification, it was the lower of the 200% billed or contracted charges. And so the issue may be that the contracted charges originally were, at a very low level, below the 200%. But as they've noted that they can charge more, they might get a higher increase in those maternity rates versus some of the other rates. And so this is going to potentially be impacting PEBB in terms of the allowed cost. So we just want to make sure, because they do have room on the contract to move to get to the 200%. And so we want to make sure they're not essentially increasing well above what market rates are, or what would be happening for the rest of the Medicare 3% or 3.5%. I guess it's 4% actually this year, but that level of increase.
It looks like Sean has his hand up. Sean?
Yeah, I just want to point out that pre-pandemic, maybe Ali, you can help me with the dates here. Pre-pandemic land feels fuzzy and compressed together. So maybe it was the year before, maybe it was the 2 years before, I can't remember. But the point is, the PEBB board did a pretty significant deep dive in a strategic planning process to try to get on top of growing costs that we might be able to influence. So the task was, what are growing costs that we might be able to do something about? And so we ended up doing deep data analysis dive, and what we ended up with, as I recall, was diabetes, costs increasing, utilization's increasing, everything's increasing. The high cost, the cost of pregnancy and birth, that was the second one. And then depression. Those were the three things that the data showed that we were heading towards problems related to cost, utilization, unit cost increases, etc. And so here we are, again, and those three things I've just heard in the past, 20 minutes, right? So I guess from my point of view, it's not a question of we should keep our eye on that. I feel like we've already established, yeah, those are problems. It's not a question of whether those are problems. Those are problems, because we knew that before the pandemic. I feel like now the question is, what are we going to do? And for diabetes, we had a plan to focus on pre-diabetes worksite wellness and coordination of care between the employer and the plans related to funneling people into diabetes prevention programs and such, as well as a general worksite wellness, change in the food environment. And then the pandemic hit and all that just scattered to the four winds sort of thing. So, and then I don't think we ever really developed this, a strategic strategy related to pregnancy and those costs. And although I do think that we had some like Siobhan was just saying, we had some ways of addressing it. But I given the depression's kind of an additional tough nut to crack. I mean, these are three very difficult things to just sort of turn the ship on. But there are three themes that continuously come up, and they came up when we did a strategic planning. So it's like I almost don't think that we need to do a planning again, because it's like we heard this song before. Now I just want to start talking about like let's reinvent some strategies here and like get back to business. And so I'm just, again, not this meeting, but I'm just putting it out there again. Like we've been here before, and really started thinking about strategies and so on. And I'm just calling that back in, I guess.
Yeah. So
Thanks, Sean.
Yeah.
I just want to
Go
make
ahead.
sure Ali has a chance to comment too.
Okay.
Yeah, I was just going to suggest some of the interventions that Sean mentioned, especially around prediabetes. We have data, I think, now that we can bring back to the board and maybe kind of look back at some of the other interventions around depression, screening, and pregnancy, and just kind of revisit maybe that retreat. And like you said, coming out of the pandemic, rather than backtrack, what's really have some focused strategies on what steps to take forward to I guess go to the next level. We can bring the plans in as well to talk about what they've done, if that makes sense, Sean.
Yeah, I mean, I think that's a good start,
Okay.
but we have like many years now of this being known as a problem. So it's like clearly whatever we're doing,
Yeah.
plans we're doing isn't doing it, because it's still going up. So I guess I'm interested in conversations about what can we change, not how great we're already doing, because obviously there's like we're not solving. So or at least getting it stabilized or downtrend, like they're still going up. So and that was 5 years ago. So as long as the conversation is focused on what are we changing rather than how are we already like got it nailed in, that would be productive, I think. Thanks.
Yeah, Sean, I guess to your 3 points, I mean, I think we, at least Mercer and, there was things that are going on. I trying to address all three. One, in the CL work group with the pre-diabetic drugs or weight loss drugs, we are, looking at that, with the Ozempic. So that is one area. In terms of behavioral health, I think Mercer is going to, there's been issues with access, and we're definitely diving into that. We're trying to come up with questions to ask the plans to try to address access and coordination and other issues, kind of taking a little bit bigger look into that. With the maternity, I think there's a couple of different areas where we can, a couple of different areas that can be attacked. So one is really the contracting, in terms of making sure the contracting is favorable to PEBB. But with the health equity work group, there's also a look into doulas, birth doulas, and how those birth doulas, whether coverage might help with the members, the people giving birth, and how, whether that can help make the births easier, lower cost, as well as, reduce number of C-sections or complications as a result. So I think that conversation is coming up very soon. And so maybe that might be one area where PEBB and OLEP can, talk about ways to attack maternity costs, at least on the utilization risk side versus the contracting side of things. Go.
I have a question about that. It looks like the inpatient maternity costs per admit are increasing considerably there on that slide, and this is happening at the same time that we had to do a funding assessment for at least some of the plans, and I would like to understand what is driving those increased costs, if it's increased complexity and need, or if it's administrative decisions on within the framing of the contracting, but increasing administratively in a way that is not driven by medical need or complexity.
Yeah, and I think that's part of what we're going to try to look at. And we'll dive into it in a little bit more detail. I mean, we're going in the IWG in terms of what we call the hospital monitoring report. We take a look at specific areas which the costs have increased. So in terms of the complexity, trying to see the complexity of these different maternity admits, we will dive into it. I don't think we don't necessarily have. Yeah, it's kind of like the next step. We'll take that and we'll bring the findings back.
Thanks.
Okay. Next slide. Outpatient office visits. So as mentioned earlier, the COVID vaccines is kind of skewing these numbers. As you can see, the office visit per 1,000 dropped quite a bit as people didn't quite get as many vaccinations or boosters during 22 versus 21. And then so that low cost service went away and the allowed per service office visit went up there on the right. Telemedicine visits for medical services have dropped about 50%. So, people are going back into the office and seeing them in person a lot more, but mental health and substance abuse telemed visits, essentially it's dropped a little bit, but it's been still pretty high comparatively. So people are still using mental health and substance abuse telemedicine visits over the past 3 years. Next slide. Mentioned earlier, the emergency room usage has gone up about almost 9% in this case, and you can see it's across the board. The allowed amount per ER visit has essentially just dropped just a little bit, but the overall cost is increasing. People are using it more. The intensity of those visits, level, in terms of coding, level 4, level 5, they actually dropped. So the higher cost visits have been fewer, but non-emergent visits have gone up, at least based on the NYU algorithm. So as an absolute percentage of the visits, that's increased from 18.2 to 18.9% non-emergent visits. So there is definitely a utilization increase here, and maybe using it for less emergent, less acute conditions. So additional things can be done, and that tied along with the telemed visits going down. We can try to ask the plans to do things to make those trends reverse in this case. Representative Nuss.
Hey, thanks, Emery. So unlike the inpatient situation or the maternity childbearing situation, which I feel is just way harder to get at, this always feels like an easier one to get at. Like, is this about, like, I'm not trying to pick on Kaiser, but I can't get in to see my primary care person. They're way booked out. Shit, I'm just going to go to the ER. Maybe I can do urgency care. I mean, that feels like I feel like there's been so much that's been done over the decade I've been around this to try to get all kinds of people to avoid going to the ER. This just feels like people that have good health insurance and can afford it going, I'm sick of waiting, or I can't wait, or I'm not going to wait a week to go. You know what I mean?
Yeah. Yeah, and there may be some cases of that going on. I mean, in terms of urgent care usage, that's definitely gone way up. But it's like there are people still, for whatever reason, going to the emergency room. We've done in the past like a dive into those who utilize the emergency room visits more. I don't know how much of it's because of we can take a look at the days, although with the primary care medical homes, there's a lot more primary care providers open up later and, on Saturdays and stuff like that. So, but we can look a little bit more into exactly the reasons why. But it is, it's not a very efficient use of services here.
Right. I agree. But like for
yeah.
somebody like me who like, it's like, dang it, I don't want to wait 3 days, or I can't schedule that in. I'm just going to go to the ER and I can afford the copay.
Yeah.
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 Okay.
Yeah. Unfortunately, there is a lot of that, especially in the richer plans. Yeah. Once
Yeah.
you hit your out-of-pocket
Yeah.
max, it's not going to matter.
Maybe you have to make the pain
Yeah.
point more difficult. I'm not suggesting that. That's not a position I'm taking, but maybe that's what it has to be.
Although, just to comment on that, I know you weren't at the last meetings, Representative knows, we actually did increase the copay for the Kaiser plans to be in line with the rest of the plans.
Yeah.
So it's going up from 75 to 150, correct?
Yeah.
I mean, that probably makes me go, okay. How bad is it? And I'm sure I'm the least well-paid person on this Zoom. So,
Don, did you want to comment?
Yes, please. One of the things that I think we're still coming out of is the pandemic, in which we saw decreased appropriate utilization of emergency departments, and people were dying at home with their strokes and heart attacks because they were afraid to come to the emergency department because they were going to get COVID there, or have to wait because it was so full with people with COVID. And so I'll be interested. Yeah. So I'll be interested to see how that plays out over the course of time. I think that our access to outpatient care, especially with telehealth, has increased so massively, telehealth specifically, that we have a whole bunch of dynamics going on at the same time.
Wow. Okay.
Also, I've been watching this for a long time and working with it in various roles, and I think you make really good points, and the board has acted as Siobhan said.
I feel like you're making good points too. Emery, is our ER visit coming? I mean, I know it's been high and we were trying to get it down, but like, are we back to sort of more historic levels of usage based on that analysis or that observation that was just made?
Yeah, you are kind of, it's pretty close to where it was before. I think in the past it's been about 200, and then the PEBB board has increased the copays and that's brought it down. But you are definitely creeping. They are creeping up to where they were before.
This is why I like being on this board, because as a policymaker, I get to wrestle with like things I do for, at the 1,000-foot level with 90 other people for the whole state. It's like, oh, I get to see how it plays out. Like, is it actually working in the real world, or not?
We appreciate it.
Yeah, it's useful to me. It's a good, being on this board is a good field trip. Okay, I'm going back on mute.
Thank you. I want to acknowledge the massive shift in telehealth in a very concrete way. Before the pandemic, a whole lot of insurers did not want to cover telehealth at all. They came kicking and screaming. Another thing that I've been studying for 10 or 15 years, and they just didn't have the evidence that they wanted to know that it was going to be helpful and useful and conducted for quality care. And the pandemic forced that transition, and it brought them into what I consider to be the 21st century. And so now we have an entirely different model of delivering care that includes a growing sort of awareness of what quality remote care looks like, and it can be delivered at a much lower cost. So the plans and the providers, all of us, are seeing the new models and how much of appropriate care can and should be delivered remotely, and then what parts are appropriate for outpatient or emergency urgent care, and then the smaller percentage that is appropriate emergency and inpatient care. And my feeling is that we have always had preventable inpatient and emergency care that could have and should have been managed in these other settings, less costly, but also more effective and better quality outcomes for people if we can get in earlier, just like the DPP programs to prevent diabetes. So that is something that I am looking for from our plans, and a very intentional optimization of those less invasive and less costly ways to deliver what our members need in the ways and the places and the times that they need it and want it. And that's what I think telehealth and outpatient ought to be doing, much more of a proportion of the delivery of care and much less in the emergency and inpatient settings. Thank you. I'll get off my soapbox now.
Thanks, Dawn.
Okay, thank you. Definitely. Yeah, thanks for the conversation. I mean, there's a lot of areas where, you know, we can definitely try to explore, especially with the upcoming potential retreat in terms of where PEBB wants to really impact healthcare. And so, you know, taking a look at those. Next slide. Go through these just kind of quickly. Laboratory services, not much change here. I mentioned earlier, COVID tests, most highly utilized service for 22 was 18% of the total allowed, although it did decrease by 25%. So, you know, a very significant number of lab tests that were being performed. Next slide. Radiology services, the services per thousand is going up a bit, you know, as some of these services, as members are coming back and using these services and having more surgeries and stuff like that, but the overall cost basically stayed flat. Although, you know, there's some stuff that we may want to look at, like there's one CPT code there down below, which had the largest cost increase, and that's due to more services being performed at non-capped facilities, so those that aren't subject to 200% Medicare rule, and those costs were 2-3 times higher per service. So, you know, where services are being performed continues to be an issue, and maybe trying to get the contracting so that the cost difference isn't nearly as big in this case. So that's some of the things that we'll be hopefully looking at in the IWG presentation on hospital services. Next slide. Prescription drugs are covering the next few slides. So I mentioned earlier the cost per member per month, a year, or have been increasing quite a bit. Allowed has been increasing 16% for Province Choice and 10% for statewide. The paid amounts increasing about the same amount. Specialty allowed increasing about 14%. So, you know, the majority of the cost really with specialty increasing that cost in this case. Next slide. Taking a look at drugs excluding specialty on this slide, you can see that the allowed per brand increased quite a bit, 30%. But don't worry. Some of it is prescription drug cost increases, but a lot of it is due to the vaccine. So some of the vaccines that were included here as a brand drug with a $40 allowed cost for the administrative fee went away. And so the services that were left over were just the more typical brand drugs. And so the cost kind of went back to where on average the brand drugs usually are. But that is a pretty big increase. But COVID vaccines really impacted that amount. Generic utilization, at least on a percentage, increased by 1.3 points to 84.6. That sounds good, but COVID vaccines were considered brand, which brought down the overall generic utilization. So a lot of that's kind of because you're losing brand vaccines. So it's not necessarily great news in that case. But overall, you know, as mentioned before, prescription drugs is increasing 10%. Bob is coming back as rebates, but continues to be a big cost driver for PEBB. Next slide. And then specialty drugs, so taking a look at specialty drugs, in terms of specialty drugs, the utilization is going up. and allowed on average is about the same, but utilization is going up quite a bit, especially with Kaiser HMO and Kaiser deductible. Some of the other information on the prior slides talks about some of the most impactful specialty drugs, like the rheumatoid arthritis ones. And then if you remove the impact of specialty, the allowed cost increase of 3.3% would have been 1.8. So especially drugs is about half of the cost increase. And over, I think, the most recent utilization reports, that's about typical. So especially drugs really is kind of contributing half of the overall increases for PEB medical costs on an ongoing basis. Next slide. So just kind of to recap some areas, I think mental health, we've talked a lot about that, and looking into the coordination, especially with maybe with those who have social determinants, identifying those proactively, or at least tying in those who are having the mental health issues and with the medical, and trying to treat them holistically and direct them to the right areas. And that's kind of with the social determinants as well. Higher intensity mental behavioral health services, what can the plans do to overall impact those members? And these are things that, we can talk about usage for the surpluses based on RBC, as well as with the retreat in terms of specific actions that the PEB board may want to have the plans address or fund in this case. Diabetes, again, to Sean's point, top spending category, increasing prescription drug costs. What can you do to prevent people, or with Ozempic and some of the other higher cost drugs, or drugs that are actually increasing in cost for diabetes, how to manage those. Next slide. And especially we've talked a lot about that. And then the rising costs, just managing and identifying, especially 3.4%. Right now, Medicare increased the facility fees by 4%, so that's above the 3.4%. So we're, immediately up against the limit. And so trying to make sure that PEB, is managing those costs, that, the care of the members, the whole care of the members is better, not just, you managing the risk of the members, bringing down the overall risk of those members, overall costs, as well as the contracting aspects of it. So it's really, really big topic, which I think we've all been trying to address for the last few years, and hopefully we're making a difference. But we can definitely try to do a little bit more in this case. And with that, I will open up for any final questions, comments.
I want to appreciate all this data. Thank you. And a reminder to the board that we will be delving into our planning again this fall in a retreat. Do folks have any other comments or questions? Right, it does not look like it at this time. We are scheduled for a break after your presentation. So I have 10:58 on my clock. We're a little bit ahead of schedule, so I'm going to give us until 11:10. I'll put that in the chat, and I'll see everyone at 11:10. Thanks all. Welcome back from break, everyone. Emery, are you here?
I am here.
All right, I'm going to let you take it over again with the risk-based capital update.
Great, thank you, Chair. This presentation and the next presentation are actually kind of aligned in terms of what we're talking about. So the Risk Stabilization Fund is essentially the amount of money that PEB has above essentially the limits or the reserves that are necessary, basically to help pay for additional fluctuations in costs. And so what we do is we take a look at the funding, and we can move on to the next slide. What we do is we take a look at the funding and we look at the projected costs over the next few years, so we can give a preview of where costs are coming in, as well as potential areas, when there might be some concerns if costs increase beyond where we're expecting it. And so, for example, if trends come in higher, we can take a look at the funding versus the cost increases to essentially say, well, this is the amount of money that potentially PEB is at risk, or that PEB would need to make plan design changes in order to meet the 3.4%. So we take a look over the next few years based on the most recent data, the expectation of where costs are going to be, and then compare that against what we say is the RBC target, which is the amount that would help protect PEB from unexpected costs or really bad claims experience, and take a look at the amount of surplus that's remaining or actual deficit if the situation arises. So we do take a look at historical. The target was based on Monte Carlo modeling as well as historical fluctuations to help develop a range, and based on that range, PEB board elected to select the target. Right now, we're targeting the middle of that range, and that's going to be shown on the next few slides. But moving on, the risk-based capital, this just talks about what risk-based capital is. It's from the National Association of Insurance Commissioners, or the NAIC. It basically provides an amount that, or a level of funding, amount of capital that insurance companies need to have in order to appropriately be funded to offset for essentially their underwriting, their all the risks that they take in terms of underwriting insurance for everyone. And so there's minimum levels. If you fall below minimum level, then you're potentially at risk. So it provides a cushion against insolvency. There's different levels of risk. For PEB, we're mainly concerned about underwriting, which is essentially on the next slide. It's essentially the projection of claims from one year to the next. What we do during the renewal cycle, which we just ended, take a look at the base year claims, and then we add in trend, we add in changes in population, legislation based on the what happens with Oregon legislature or federal government, and then any potential large claims fluctuations, that sort of thing. So those things are underwriting areas of underwriting risk, and we calculate trends, we apply those trends, and there may be fluctuations from those trends depending on those various things, where your population's healthier, sicker, you have large claims, or 2020 you had COVID, where originally maybe we expected costs to go up during the initial month or but quickly went down because everyone was locked down and people didn't want to go to the doctor's office. And so that changed how healthcare was delivered, and also changed, essentially underwriting the risks and the PEB situation with the stabilization fund. And so once what we do is we project out costs. We try to account for as much of the underwriting risk as possible, but we don't necessarily can. And then what actually happens, we take a look at it, and then we project out over the next few years in this report. So next slide. Taking a look at the RBC, these are a summary of the results. So the cost, at least projected for 23 per employee per month, it is improving slightly. It's not a big decrease, but it does improve a little bit. We do base 24 on the renewal results with the premiums, as well as using trend rates to project out the self-insured cost. So, what we had originally projected for claims for 24, a little bit better for self-insured, the Kaiser premiums and the Kaiser premiums, and we update with enrollment. But overall costs are a little bit better. There's still continued switching to the lower cost plans in this case. The reprojected 23 has a surplus of 45 million, which is an increase over the prior report based on the improved cost. 24 is a surplus of 13 million. That does include the funding assessments that PEBB board elected to essentially put on to help bring the overall cost increase up to the 3.4%. So it is an improvement, but it's not a significant improvement over the situation from the last renewal. What is new is the 2025 transfer, and the transfer has to be done before, I think, May of 2025. We did put it in for 2025, but $90 million due to Senate Bill 1049. We included a penalty for 26 of $9 million as an estimate for this, and that is impacting the results. And Representative Mills.
Okay, first of all, I want to assure you all I had nothing to do with that 90 million transfer. Can you explain the 9 million penalty? I just don't understand what that is. I know what the transfer is. I know what the stability fund is, all that. What's the penalty?
Yeah,
I could take that, Rep. Mills. It's a federal penalty. It's a OMB A87 penalty for basically using federal dollars earmarked for employee benefits and transferring it to a general purpose fund, i.e. the general fund, by legislative direction. So they essentially take the federal participation rate and apply a penalty to the state. And it's been around 8% in the past. And I actually have a presentation on this following this report.
Okay, all right. Then I'll save my.
Yeah.
I'll understand it better than like this is. I never heard of that before. Shocking.
Okay.
Yet another thing in the healthcare world that I've never heard of.
This is not the first time.
Okay. So, Allie, just humor me for a minute. If for some reason something really bad happens, we can go back to the legislature and say, you got to give us back that 90 million, right? Like that could be a thing potentially. Like you could see where a group of budget writers trying to find money saying, this feels like a risk we can take. We seem pretty well situated. PEBB does a good job. We've got a good consultant. Again, this is me just totally speculating here. I wasn't in the room when this happened. I'm sure I voted for it. But if something really bad happened, we could go back to the budget people and say, you can't do this.
Yeah, I mean, we can for sure. The budget people from legislative fiscal and the executive department, CFO's office, they keep pretty close tabs on PEB's self-insured business, how it's going, and when they see surpluses, that, and I'll talk about this again in a little bit, but it's kind of, I don't want to call it a piggy bank, but that's kind of how they treated it in the past.
Yes, I know what you mean. Yes, I get it. Oh man, I drew some hands. I mean, we, the legislature, have done this with surpluses in licensure boards periodically. I mean, this is sort of the looking under the couch cushions kind of stuff that we periodically engage in. Okay. Yeah. All right. Going back
we'll
on
have a little more in-depth discussion following up, but yeah, you're exactly right.
No, you want to comment too, Sean? Go ahead.
Ali will give the very clear-eyed and even-handed response. I'll be more blunt. That we get every time the legislature comes and dips into our reserves. We get penalized because it's illegal. Like you can't do that with federal funds, and these penalties are no joke. Like 8%. We pay millions of dollars. Like we were just talking about this increase in diabetic medicine costs, or these high, the social determinants of health, and we talked about it for like 30 minutes, 20 minutes. That was $15 million. $9 million was a penalty, and it just evaporates into the federal government, like it's just gone. And so, like, yes, technically we could pull the money back if we end up in a crisis, but you still lost the $9 million forever. The government of the Oregon just gave the federal government $9 million more back because they didn't do accounting well. Like, they transferred funds from one account to another in a way that it foolishly costs money. It's like you go to an ATM and it's not your bank, and you have to pay the
I'm
withdrawal
sorry I
fees.
said anything.
Well, I'm just being like, just so it's super clear, every
No,
time they
sure.
do it, we pay a penalty, and it's an incredibly large penalty. And
Somebody
it's
thought the penalty was worth it, apparently.
yeah,
but
clearly.
Yeah,
But-
yeah, not me though.
Right.
Okay.
Thanks.
Love you, Sean.
Yeah,
Don't say that too loud in the Capitol, okay?
I appreciate you being here, Rob. I do.
You got to be a little more politically correct when you talk to some other people in the legislature, okay?
I know you.
So
I'm
that's just some
giving
helpful
it to you
feedback.
straight.
Yeah, exactly. Okay, just want to give you that coaching. Okay.
Thank you. I'll take that.
So with that 90 million transfer and the 9 million penalty, the stabilization fund is projected to be below the target in 2026 by about 34 million. So I think in the prior report, they were targeting kind of pretty much at the target. Now it's going to be below. That said, if costs are contained at 3.4%, essentially you'll be fine. But if trends higher than expected, you'll drop below the target in 2025. So you can see it's like a couple points here and there on the trend can greatly impact the financial situation at PEBB. So when we're talking in the retreat about potential ways to maybe help members and to manage their costs going forward, that every bit there helps in terms of keeping the trend down and potentially reducing the amount of maybe plan changes or other things that may be done in order to keep to that 3.4%. But moving on to the next slide. So this shows the results essentially by year from what we just talked about. So we used the latest claims enrollment data. So in terms of claims, it's through May of 23, and for enrollment, it's through June of 23. And so we use that as well as the actual composite rate for and funding moving forward. We included that $90 million transfer in 25. And so you can see in the purple line, it drops well down. So it starts out the projected ending fund balance for 23 is just under 400 million. Your target's about 233 million. So there is a surplus there. In 24, the cost of projected increase to funding balance and balance does increase a little bit, but kind of in line with its reserve target. But then in 25, that purple line drops way down in terms of ending fund balance as the 90 million gets transferred out. And this is based on the Mercer trends. So if costs increase more than that 3.4%, this is the market-based trends, then you basically will start seeing a decrease in your ending fund balance, pretty significant one, where in 26 you end up below the target. So, this is, I guess, a sign or showing you graphically what needs to be done, that in terms of needs to be done in terms of keeping the costs to that 3.4%. Otherwise, you might put yourself in a deficit position compared to the ending fund balance target, based on just the trend rates as they are. Next slide. The cost versus funding, a little bit of a look, at least historically, and a future projection. 2.4% increase in funding, 2% cost for 22. You can see 23, the cost and the funding. And then as we start going into 24, 25, the costs are increasing more than the funding. The funding gets limited to 3.4% for 24, thanks to the funding assessment and some surplus from prior years. Year funding is a little bit higher, but once you get to 25, 26, that's where the deficits start to happen and putting you into a deficit position. So costs, at least using the market trend rates, are above that 3.4% by about 2.5 points in this case. And so that compounding impact does have a negative impact on the PEBB balance. Next slide. Historically, we've shown that PEBB has held below that 3.4% growth. Some of it thanks to COVID, unfortunately, in 2020, where the cost drops down quite a bit. And then you can see that the growth line is, pretty similar to that 3.4%, maybe just a little bit above. But overall, we take a look from 2018 to 2024, you're below that 3.4%. That builds up the surplus, which unfortunately was transferred out, or will be transferred out from the balance. But overall, PEBB has kept to that 3.4% over time. Next slide. If you do have that keep cost to that 3.4%, you can see that the fund balance does decrease in 25 with that transfer, but you still remain above the reserve target, in this case by about 70 million or so over 25 and 26. So reduction in costs helps keep that fund balance high, but if trends are unfortunately 6-7%, that you're going to have to make plan changes likely to keep to that 3.4% or spend down the surplus to a point where you might be below your reserve target. Next slide. This is showing the different scenarios, including kind of more of a worst case scenario as well. So you have 3 lines. The purple is at 3.4% increase. The market trend is the green. So you can see it's a little bit below, and you can see the delta between the purple and the green. And these are the ending balances. So each year kind of does the compounding. And so that's why you see a little bit bigger of a decrease where you end up below the target by about 34 million in 26 under market trend. But if you keep your cost at the 3.4, you're about 70 million above that target. But if market trends are actually higher by a couple of points over the next 3 years, the impact on the fund balance is more significant. You can see the decrease in 24 as costs kind of come in. Those rates are set right now, so we do have those set, but if costs come in, trend is higher, utilization's higher, contracting's not as good as we have been historically. You start seeing a deficit in 24, or at least a decrease compared to where we originally projected, and then it continues in 25 and 26 if no changes are made to impact those costs. And welcome back, Shimon. So I guess this is kind of a warning. We are talking about potential ways to impact that trend line to make it closer to that purple versus the green or blue. And so there may be, we can talk about things during the retreat or in future meetings to help keep PEBB as close to that purple line as you have been over the past few years. Next one. Just some data assumptions used here. I actually won't go through this, but I did mention to the representative, we did increase the trend. The medical trend is 6.5. That's what we used in the renewal, but it is higher than what we've used in prior years. So we have increased that by about a point. With the pharmacy keeping about 10%, that gets to about a little bit over 7% increase between medical and pharmacy. Dental and vision both increased by a small amount.
That trend does not seem bad, given what I remember pre-pandemic when I was doing union negotiating work and dealing with this, or that trend seems in line with what I remember prior to the pandemic.
Yeah, trends can fluctuate. I think there's different times. I don't know how many of us were doing healthcare in the 90s, where the trends were well into double digits. And I think early 2000s, they were well into double digits. And so your costs were increasing significantly. And then it's definitely moderated. The trends, you know, we do talk about 7% trend, but you have 7% trend on grocery and gas and other things. You know, that's a huge hit to people. PEB has done very well to keep it at 3.4 and kind of keeping contributions not increasing nearly as much for the members as well as the out-of-pocket costs. But you know, there is a delta between what PEB is limited to and what we're seeing in the marketplace, and managing to it gets more and more difficult every year. Next slide. We're getting to appendices. So the numbers here are the ones, you know, in terms of projections. So you can take a look at the results as well as that 90 million transfer that's listed there. This is the market trend rate. If you want to go through that detail, I will not. Next slide should be the 3.4% scenario. Thank you. And then the following slide. Next two slides have the RBC targets. So you can see for the various plans, the different targets, the low, the high, as well as the middle, and then the totals here. And then this is 23, 24, and then 25 and 26 on this next following slide. Thank you. And that's actually the presentation. And with that, I'll turn it over to Ali for his presentation.
Thanks, Emery. One more slide, Rose. There we go. So as I mentioned earlier in the meeting, staff wanted to bring a follow-up presentation to the biannual RBC report for the reasons that Sean and Repnos raised earlier around funding sweeps, and raised the possibility of the board taking a policy position around their stabilization, around your stabilization fund reserve account. And you might recall that recent SOS audit suggested that perhaps having a board policy or plan could help ensure reserve funds are more effectively used towards meeting the board's goals and containing costs, and would potentially discourage legislative funding sweeps. I did want to mention that the board currently does have a policy for determining the appropriate reserve target level, which Emery just covered in the RBC, and I'll talk a little bit more about, but it does not have a policy for actions to take when the reserve reaches higher or lower than targeted levels. Next slide, please. So what challenges exist when considering a policy? The biggest challenge right now is the 3.4% statutory cap that limits premium and expenditure increases each year. And you might remember in this most recent renewal, when the board lands under 3.4%, if it actually adopts a renewal at a composite rate of under 3.4%, that essentially lowers the baseline composite rate for the next renewal next year. So you're effectively facing a stricter than 3.4% test the following year. You're underfunding the trend, so to speak. So using excess reserves to buy down rates can actually present a more challenging renewal the following year. If the board adds a funding assessment, which it did this year, to get to 3.4%, and then the legislature enacts a funding sweep, which they did, the federal government, as I mentioned, assesses an OMB 87 penalty for, as Sean said, it really is an illegal transfer. That's what they call it, for transferring those federal funds to the general fund and not for employee benefit costs. So we get to transfer that money, and then we also are stuck with paying the penalty of 8 to 12%, and I'll show you the amount of the sweeps in the past. So the point of this slide really is to get to the current environment where the legislature has shown a willingness to sweep funds from PEB and have PEB eat the penalty. It doesn't make sense to add a funding assessment to get to 3.4% and then have those funds get swept and essentially pay a penalty on top of it. Next slide, please.
Looks like we have a
Oh.
question from Representative Nose.
Sure.
The lone legislator here. So Ollie, I hope you're allowed to answer this in a public forum. Did you explain this to the budget people?
Oh, yeah.
And they went with it anyway.
Oh, yeah.
Okay.
I
All
think
right.
there were sessions in the past that it was closely looked at along with a couple different options. And the step was not taken.
Well,
But then in 2017, the step was taken. And so I think that kind of opened the door.
I mean, so, I'm trying to think how to say this in a more politically correct way. Maybe in a moment when we're in a recession and there's a surplus and we're looking at kicking off people off the Oregon Health Plan, maybe this is the kind of thing that makes sense. Or I say to you, well, Ollie, PEB, look at what my options were. Okay. But I might be questioning at this moment if this was the best idea, but I wasn't asked.
Yeah.
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 I'm going to someone's going to watch this and I'm going to get a phone call. I'm going to say, I'm going to say, you're welcome to take me off this board, or maybe you should have asked my thought about it.
You raise valid points, and again, that's the point of the discussion around a policy and whether it would actually deter those decisions. I'm not sure, but it's worth having a discussion.
To be honest with you, but I think it's a good idea. But I suspect not.
Yeah. All right. So a little bit of background, just briefly. So the Stabilization Fund Reserve account is held in state treasury. We can't actually invest those funds, but we do earn interest earnings on the funds held there. It's made up mostly of surpluses from our self-insured plans, from premiums that exceed claims and administration costs paid out in a given year. What distinguishes it from a fully insured plan is if we had all fully insured plans, those excess funds or surpluses would be retained by the carrier, but in our self-insured business, the funds are PEBs to maintain. Next slide, please. So the board uses these funds in a variety of ways that are authorized in statute, and they include subsidizing the employee premium share from time to time. We've had some different situations. I remember we changed the tiering, that we did a small subsidy. We funded programs designed to reduce premium increases, and we've also used funds to buy down carrier rates. Also to pay for healthcare improvements for members like vaccine incentives, benefit enhancements, and recently removing the prior auth on behavioral health and other wellness opportunities that we've invested in. But as Emery mentioned, the most important purpose for the reserve account in the stabilization fund is to ensure that sufficient funds are available to cover non-predicted large increases in claims costs for the self-insured plans that PEB administers. And we always have said that, we need to maintain a certain level of reserve in case of a pandemic, and then we actually see a pandemic and then our reserve actually increases rather than gets annihilated. So we're in a pretty good position, as Emery mentioned, but again, it's worth having this policy after seeing the latest policy discussion after seeing the latest sweep.
And
Next slide,
Ollie,
please. Yeah.
I just wanted to make a comment too. Just there was a move in the 2000s that the PEB board made to go to self-insured, and just seeing all of the trends over time, that really has saved PEB quite a bit of money. And we also know that MOTA recently went to self-insured. And so I just want to highlight the past decisions have been fiscally sound decisions on the board around that.
Yeah, it's definitely obviously been a real success for PEB. for sure. And you have to have the money, in reserve to go self-insured, or you're faced with buying like stop loss insurance, or taking a different step. But I think it is, we've seen over the years, it's been a successful endeavor for PEB. Next slide, please. So how does the board determine the budget target required in the stabilization fund? As you saw in the RBC report, we worked with Mercer to project an amount in the stabilization fund sufficient to meet both anticipated and unanticipated fluctuations in claims costs. Upon going self-insured in the early 2000s, the board identified the target level of funding as mid-low, which you saw, I think it might be in the appendix, but the various ranges are reflected there. Mid-low was probably selected at the time because PEB didn't exactly have a flush account in reserve, and but a few years later, the board elected to change that target to the mid-range, which is reflected in today's RBC report. So that's the current target policy. Next slide, please. This is showing the 3 legislative funding sweeps, including the most recent one this session. And all 3 sweeps together combined for about $273 million. And if you added the federal penalties on top of that, it would total close to $300 million.
Wow, that's actually a lot. That's actually more than I would have thought. I would have thought this would have been more of a one-time, one-off. Very interesting.
Yeah, I was a little surprised, to be candid, this go around, just because the revenue picture looked a little bit better than anticipated. But yeah, that's kind of where we're
at. Some of my energy when I was speaking was really coming from a place that it appears that this is now like an established pattern. And it's that which has concerned me. And I've actually gotten to the point where I've seriously considered, suggesting the idea of maybe we should be fully insured just so we don't have a fund that can be rated. But it kind of is an incredible amount of funds to be paying in penalties. Because I do hear your point. Like if we are in a like major recession, I get it. And it's like a decision between like some people not having insurance and dying versus, okay. But like in a year like this where we had a surplus, we were actually sending money back to, Oregonians. It's just super hard to understand. So it's just sort of a pattern at this point. So we're just trying to wrestle with what to do, I think.
Yep, I get it.
Next slide, please. So as you saw in the RBC presentation and in this chart, that PEB's the board, you have been able to withstand the funding sweeps and still stay at a fully funded target reserve, and been able to build back up those excess reserves over time. But there's a risk involved in expecting that to continue. And you saw the picture that Emory showed of, if trend comes in as expected and not necessarily under 3.4%, you obviously have the ability to set premiums at 3.4%, but if actual costs end up higher than that, then that would put the board potentially in jeopardy in 2026. Next slide, please. So that brings us to our conclusion, where we look at some options that the board can consider pursuing. The first is to consider revisiting previous conversations related to upping the reserve funding target to another level. So going from the midpoint to middle high and try and protect some additional reserves. I think when the budget writers look at our reserves, they look at the amount over the fully funded target. So you would be essentially going from a fully funded midpoint to a fully funded middle high. So that could be effective. The next option is to pursue a draft legislative concept that allows for a different approach or calculation for the 3.4% annual cap that doesn't penalize PEBB when it's coming in underneath the cap. So if we adopted a 3.1% composite rate renewal, you could, I'm just throwing this out there, take credit for a 3.4% composite rate, and this totally flies in the face of all actuarial rules, Emory. So this is something that we could definitely give some thought to and bring back some options around what a legislative concept would look like, revamping that 3.4% test.
Hey, Ollie, I mean,
Yeah.
I hear you saying we need to have more options out there on that. I think it might be helpful for the board just to more fully understand the legislative restrictions that we're currently under and how, you know, we don't get claims data till the following year, and sometimes that trend changes. I don't know if we want to delve into that now or you want to wait. I just think,
Yeah.
you know, it's kind of a challenge to get your head around all of the specifics on the 3.4%.
Yeah, I mean, it's kind of one of those, where do you start? There's a lot of considerations. You know, part of the problem is in statute, it's pretty straightforward. Increased premiums cannot increase at a composite over 3.4% year over year. And the second test is actual costs. And the board has control on the premiums, but not necessarily on actual costs. And a variable year, you know, they can definitely exceed 3.4% or even what we're projecting. So there's inherent risk in being able to meet that 3.4% test each year. The board's been able to manage to it every year. But you know, I think, again, when you're looking at balancing to it, it might not be the best decision. It might not lead to the best decisions as far as adding like a funding assessment to get to that 3.4% level, when they're going to turn around and take those funds, and then you will end up paying a penalty on top of it. So
yeah, thanks for going back over that. And yes, I mean, that both makes sense. And we also, as a board, have to grapple with such a hard line on the test. That means if we don't raise the rates to the 3.4%, we're coming from that much further behind when the trend rate goes up the following year.
Yeah. And there's a statewide cost growth target committee meeting tomorrow, and that is something that PEBB and OEB have signed up for and comply with. Obviously, but there's a lot more flexibility within that direction of the committee and kind of what folks have signed up for. And I think, you know, that makes a little bit more sense when there are conditions that may exist within the marketplace that you would make an exception for, or if the board is actually able to be more efficient and drive below 3.4%, then it shouldn't be faced with adding costs to get to that level. The third option is to look at greater investments. Talked about this a little bit. So specific targeted board interests, like addressing reimbursement for behavioral health, something we've talked about recently, the board's talked about. Addressing social determinants of health, which Sean mentioned earlier. Contribution changes and other strategies focused on reducing the long-term trends and risk scores that we've seen increase. So there's a lot of potential there. When you're talking about $90 million in a year, that's a lot of money. So that's a pretty significant investment or investments. The last option is to take no action at this time, bring this back to the board to the fall retreat with maybe some more specifics around potential options to take, such as potential what a draft LC might look like, and then some specific investment options and what they might look like, and then decide on some next steps from there. But that concludes my presentation, and be happy to answer any questions.
Go ahead, Sean.
I appreciate this overview and some good thinking about it. It occurs to me, Ali, that there might be two other options. And I'm not saying that they're necessarily good options, but they're technically things we could do. So one, or I guess number 5, would be the opposite of number 1. So in other words, that we change our target to like the lowest possible, like, a low amount of reserves, with the intention of being like, you just can't go below, like it's just too dangerous to raid the funds anymore, because it's just like it's already operating on like fairly narrow margin. And if they do, it's like we may need to ask money from them rather than the other way around, because it's just like it's like a less tempting target because it's like we keep the reserves so low, right? So that's one. I'm not advocating necessarily for any. I'm just saying like that is technically an option. I don't know if that would be effective at all, as I don't know if number 1 would be effective at all, but because they may just like increase the amount that they take. So I mean, who knows? So, but anyway, that's number 5. Number 6, and I wonder if this is true. So this is a little bit more of a question rather than a statement, but I'm just going to suggest it as an option. So let's say that the legislature decides that they are going to raid the fund again. And so that's established, that's a thing. So now it's only a question of how. And so what they've been doing is just like a direct cash transfer, kind of ATM style, and that's where we get this penalty. I suppose if they were in a place where they were listening, we could suggest an alternative way to transfer the same amount of money, since they're taking the money anyway. And the way to transfer that would avoid a penalty. And so this is my question. Is this true, or am I making this up? But theoretically, in my mind, we could having already decided that they're raiding us, that we could transfer the money in a way that we basically buy down the funding assessment for each of the agencies below whatever it is that we were going to charge them based on the approved budget, the trend rate, to match the number that they're looking for that they're going to raid, right? And so it's like more cash is freed up in the system, then they can use that for whatever they were going to use it for, and we don't get a penalty, right? I mean, I hesitate to even mention that, because then it's basically just like, well, they're just going to do that every year. But if we're at a place where they're kind of raiding us every year anyway, it's maybe this is like only a suggestion, like after they've already decided to do this, could we go back and suggest, like, before you take the cash, can we transfer the money like this? Like, anyway, so is that even possible? Like, would that even work?
Yeah, they actually looked at that in the past, and unfortunately, it's estimated about 45% of PEB premium dollars are paid for with general fund. So by transferring 90 million to the general fund directly, you're filling a $90 million general fund hole. Whereas, if you do it basically as a buyback by agency, you'd only get 45%.
So you'd have to transfer even more money in order to get, you'd have to buy it down way more than 90 million in order to get 90 million back in the general fund, is what you're saying.
Yeah,
Okay.
and yeah, I mean, it's a good idea, and I've advocated and thought that would have some impact in savings even for other funded fee-based programs. But
Okay, I see.
yeah.
All right, withdrawn. Okay, thanks.
Yeah.
Any
So I think at this
other?
point, Shavana, yeah, I mean, unless there's other comments, I think, we're not looking for a decision today, but it's definitely, with the latest sweep, something to consider, that we could bring back a little more condensed discussion, or more focused with a little more specifics around a draft legislative concept or some, targeted investments for the next, for the board retreat, and carve out some time for that.
That sounds right. Thank you, Ollie. All right, so I believe we're going to move on to the next agenda item. Glenn, are you here? Glenn Bailey is going to be presenting. Yes, I'm going to hand it over to you.
Thank you, Siobhan. I don't know if I'll be able to top that lively discussion earlier on the fund sweep, but what I wanted to do is, since the session is over, I wanted to give you kind of an update on what happened during the session. Specifically, we'll give you just a general how many bills were watched, how many bills passed, and then their priority. And the next thing is I'll quickly go through the bills because it turned out to be around 13, but I'll try and kind of move along because I only have 20 minutes here. First of all, we had 121 bills. And before I go on, I just want to let you know that I'm the coordinator for the legislative program here at PEBB and OEB, but I work with a team of 4 to 6 staff members, plus Mercer, plus a number of other folks who put in a lot of work here. Rose, why don't you just go to the next? Yeah. So for the overall session, we watched 121 bills for PEB and OEB, and they ranged in priority. And what that means for those who don't, know or have question, priority 1 indicates a bill that would directly affect PEB and OEB through our program, say a whole new policy. Priority 2 is those are usually benefit bills where it would have a financial impact on PEB and OEB, but not really a change to our programs. Priority 3 is same thing, but we don't estimate a cost impact. And then priority 4 and 5 are bills that we're watching, especially because of their relating clause that could affect us if it was changed. At the end of the session, we had 44 enacted, 77 not passed. Of those that were enacted, we had 2 bills that were priority 1 bills, 2 bills that were, I'm sorry, 3 bills that were priority 2, 10 bills that were priority 3, and then 29 that were priority 4 and 5. Next slide, Rose. You can skip this slide. This is just an overview of what really kind of defines the priorities. This is just a general listing of the bills that these are priority 1s through 3s. And why don't you go ahead to the next slide, Rose? The first bill, House Bill 2574, it increased coverage for what's called PrEP. These are medications that are used for people who had exposure to possible HIV to help prevent HIV. It requires hospitals to have a 30-day supply, and that OHA would provide that supply. Excuse me. Main thing for us, it would mean that we could have no cost sharing on any PrEP coverage, medications, or therapies. Next slide. We also had some modifications to what's called our Senate Bill 551 program. This is a program that PEB and OEB are participants in, where part-time faculty can be eligible for coverage under PEB and OEB if they meet certain requirements. It increased the coverage from an employee-only medical to employee-only medical, dental, and vision. It changed the eligibility to PERS eligibility. So to be eligible for the program, you had to meet PERS eligibility in the previous year, and then requires the colleges and universities to communicate annually to part-time faculty about the program, how it works, what are the benefit requirements. Next slide. There was some limitations on PBM reimbursement recoupments. It adds some criteria that are required for a PBM to recoup payments that were already made to pharmacies. And you can go to the next slide, Rose. 2994 increased hearing aid coverage. It added certain services that must be covered, and provides also that health benefit plans cannot have the coverage subject to any cost sharing, except for HSA compliant plans. Next slide, Riz. Since this is a lot, very some small information here, it's on House Bill 2002, and it's specifically the section on gender affirming care. That section requires that health benefit plans cover treatments for gender affirming care as long as they're medically necessary and meet standards of care. It also requires that health benefit plans not use kind of blanket, really cosmetic exclusions for certain gender affirming care treatments. It also requires that if they do an adverse benefit determination, that this has to be done by someone who has expertise, a provider with expertise in gender affirming care. Second big part of this is that the health benefit plans need to contract with a network of gender affirming care providers across really the state, and meet network adequacy requirements, both on geography, time, and distance. The DCBS will be developing rules for this, for them on how this is, on these different requirements for this bill.
Lynn, I think you got muted.
Oh, I'm sorry.
Yep, you're good now.
Yeah.
Okay.
I think we missed like 2 sentences, I say.
Okay. Yeah, on the House Bill 2002, it was I just wanted to say that DCBS will be developing rules for this on the benefits, and especially on the standards required to contracting with specific network providers who have gender affirming care expertise. Okay, you can go to the next slide, Riz. There was a bill to really change the public meetings law. It added additional definition to what constitutes a public meeting, allows complaints to be filed and grievances against a public body over perceived violation to be investigated by the Oregon Government Ethics Commission, and makes members of a government body subject to civil fines if it is found through this investigation. So you can go to the next slide. We also had a bill on dental plan reimbursement, and that is, of course, the reimbursement between providers and the carriers who oversee dental plans. It put limitations on the use of electronic funds transfer, and credit cards, imposes conditions on third-party network contracts, basically makes it a kind of more opt-in to opt out if there's a transfer or sale of the network or use of the network, authorizes DCBS to adopt rules related to it actually relates to a different bill, Senate Bill 1529 from previous sessions that had eliminated co-payments for primary care visits. It allows policies and plans to, if DCBS allows in the rules, to actually use the $5 to meet mental health as a cost sharing to meet mental health parity. That section of the bill actually doesn't apply to PEB and OEB plans. So, and before I go on, I just want to make sure, does anyone have any questions? I know I've been kind of skimming through these bills here. I just wanted to make sure if there weren't any questions so far. Okay. Next slide, Rose. One of the bills that was a priority one was the House Bill 3140 that removed the 3-year consulting limit. So that means that going forward, PEB and OEB no longer have to do a 3-year RFP for their consultant. I think we should thank Representative Nost, since he's the one who was championing that bill.
Murray Chin, are you still here?
I am.
Yeah, you can thank me. Don't ever say I never did nothing for you. In case I'm one of these people that ends up sweeping you a few years from now.
Next slide, Rose. You can go to the next slide. That has to deals with the OEB board, so membership. We had a bill on proton beam therapy coverage. It basically requires that proton beam therapy, that the prior authorization and utilization reviews match other forms of radiation therapy. And I know I'm going to mispronounce it, but I'll just call it what's called PANDA coverage. It's well, I'm not even going to try and pronounce it. It's a rare childhood condition. It requires treatment of PANDA, and for that it be covered. Next slide. And then we had another benefit bill here that requires prosthetic and orthotics devices that are medically necessary to restore and maintain the ability to complete activities of daily living be covered. Next slide. We also had a bill on supplemental breast cancer examination coverage. It basically said that plans cannot impose cost sharing on supplemental breast examinations. Go ahead, Ali.
Thanks, Glenn. We talked a little bit earlier about draft legislative concept on the 3.4%. I think some of these bills that have mandated benefit changes that have a cost to them. Not that they're not the right thing to do. Obviously, we have to comply, but they do eat into that 3.4%. So it might be worth working in language, that would accommodate the premium impact of some of the legislation, especially if it's significant. It can really have a detrimental impact on existing benefits that having no web offer. Just want to suggest that. Thanks.
Next bill. This is a bill that for opioid overdose reversal medication, it basically requires that hospitals and other facilities provide patients when they are released the opioid reversal medications, 2 doses of it, with information on how to administer. It does, this is to be actually handled through another division of OHA, but it could have an impact on us in that there may be, added charges that are provided, that come through from the hospitals to the plans because this medication is covered underneath PEB and OEB. So it may have a cost impact, but nothing was estimated. Well, I'm sorry, very slight amount, as you can see, was estimated at this time. And a lot will depend on how this is facilitated through other divisions at OHA and whether the hospitals use that, other method to get their supplies. Really after this, I mean, before I just wanted to discuss some brief next steps, but for the bills, were there anything else or any other bills that people had questions about? We do include when the bills are operational for PEB and OEB, as well as a link to the bill if you're interested in reading more on that, or we can provide you more information. Our next step is we have met with the different staff here, or who will be working on it, serving as implementation leads here for the bills that I've gone over. We've been developing bill action plans for them. We've also informed the carriers of these bills, since especially for the benefit bills, a lot of that will be really implemented by the carriers. So it's really kind of the next steps on that. We'll be doing a kind of a legislative debrief, probably in August on this, to go over, our system operated, how we, could improve, and any, changes possibly going forward that we might want to make.
All right, well, thank you for going over all the bills and next steps. Are there any questions?
Yeah, so I saw as we were going through that there were these estimates, 0.01 percent increase in costs and or of our premium. There was one that was like 0.5, and so on. So is there anywhere where we've added all that up and we have like a total like 0.75% increase in our premiums right off the top just from legislation? Do we have that number somewhere?
I can get that for you.
Okay.
So,
and I am assuming that the legislature did not make an adjustment, because I don't see it here, to our 3.4% cap
no,
to accommodate their new legislation. Okay.
no.
So, I mean, it makes sense to me. So just a reminder that, 3.4% is well below the normal market rate, right? So normal market rates somewhere around 8% per year, and we beat it. We're at 3.4%, and we do that every year. And so the legislature passed these laws, which again, many of them sound like good ideas, but they are imposed, and we don't get an adjustment on our 3.4% to accommodate these new laws. So it seems worthwhile to at least have that conversation about, right off the top, before we even start the year, we're going to have these increases on our premium rates. Like it's like the floor is not zero, So that seems appropriate to have that conversation, in my opinion. So.
Thanks for your comments, Sean. In my mind, Oh, yes, go ahead, Kimberly.
I just wanted to thank Glenn and the team for following all these bills. I'm sure it was a very interesting year. And when hundreds come in and you're trying to figure out what might actually get roots and go on to committee, I'm sure it makes it very interesting for Glenn and the team. But I just wanted to thank them for all their hard work, because I think this is kind of the wrap up for him. I mean, he's got a lot of work now, but for talking to us about bills for this year.
Appreciate you lifting that up, Kimberly. Thanks. It is a lot of work. And additionally, I think as we move into future years, and we're going to want to revisit the 3.4% potentially as a strategy, right? And we'll discuss that more in a retreat as a board. So any other questions for Glenn? All right. Well, thank you so much, Glenn. Oh, yeah. Go ahead, Sean.
I guess I'll just mention, like, from what I understood, from what I can see, and I think this was consistent with almost all of the bills you were describing, they all have a start date of January 1. And so
Yeah.
I think the way that this works fiscally is like our rates are what they are this year, which that we just made decisions about, which will be 2024, you know, because we're always planning for the next year, you know. So the consequences of all of these bills, as far as financially, will accumulate across 2024, but we won't be able to deliberately deal with them until 2025. Right? Am I thinking about that right?
Yeah, you are, Sean. I mean, essentially, it's an underfunding situation for 2024, and you know, the thing is I think there was one bill where they actually did give us the budget limitation on a bill, but the getting the limitations not really as big of an issue as getting credit on the 3.4%. That's the revenue side. That's the expenditure side is something we can get increases for various means, but it's that 3.4% that is the real challenge. So
yeah, I mean, just to basically the way the process works is we will, you know, analyze the bills, do a premium impact, and convert that into what it might be potentially in regards to premium dollars, and then submit a fiscal for that. But as Ali pointed out, what then they'll do is, if, you know, LFO then proposes that and with the legislation, is that they'll give us limitation, because basically what we're doing is we're asking for limitation, but it in no way do they you know, adjust our 3.4%. We always indicate in our fiscals this will challenge our capability to meet the 3.4%, but you know, that it's not a kind of a, as I would say, a fiscal request that comes with the legislation.
they can't do anything because it's in statute. I mean, that's the problem. That's where an LC would be needed.
I mean, maybe this is the place where we have a conversation with some folks about 3.4, the reserves, like that seems to be a spot where we can check in with key leaders in the legislature about, you know, why we shouldn't, why the policy that you all are contemplating maybe makes sense if we want to continue to maintain this target, which I think we do for a lot of reasons. And
Yeah, so I think, I mean, that, you know, prior to getting there, I think the board needs to have that discussion on where we're going around the 3.4% in the retreat, right? So that all of this information is informing that.
Yeah.
Ollie,
right, well,
does PEB have to check in with the governor before it can drop a bill? I should know
Well,
this.
yes,
but I don't.
it's part of
Yeah,
the
okay.
part of the LC
okay.
process. Yeah.
Okay.
But it'll start here
Well,
pretty soon. So
I mean, you all might check in with some folks on the governor's team about some of this stuff too, and the reserves and. I mean, I get all the challenges that we have. This is actually such a really good real world, grounding for me. It's a good field trip to come to this meeting and say, oh, look at all the implication of everything I worked on. It's helpful, to be honest with you. And yeah, I'll just leave it at that.
We appreciate you
probably
being
gotta
here.
Yeah.
Yeah.
I realize like coming to this meeting means like, oh God, this just makes my job harder understanding everything I'm actually doing. Okay. I should probably get going. I got to get on to my next thing. I'll see you all in August.
All right, thank you.
Cheers.
And I need to check to see if we have any public comment today, because that's the next order of business. Any public comment, Rose?
No, no public comment.
All right, so I believe we are officially adjourning at 12:20 today. So I'll see everyone in August. Thank you.
Bye,
Thank
you
you.
guys. Safe travels, Greg.
That's close. It's actually 2:20.
Thanks, everybody.
All right, bye.
Thank you.
Bye.